Welcome to the Virginia Mason Institute webinar, Beating the Clock to Stop Sepsis in 1 Hour. Virginia Mason Institute provides coaching and education to organizations in order to transform healthcare worldwide. My name is Holly Lakin, and as an Institute team member, I am proud to introduce our presenter today, Noel. Ellen is a transformation sensei at Virginia Mason Institute with in-depth knowledge and experience in coaching and team development, clinical processes, and healthcare outcomes. Prior to her work at Virginia Mason Institute, Ellen worked as an adult clinical nurse specialist and director of quality and safety. As an improvement leader, she led system-level improvement work in medication safety, nursing and care team workflow efficiencies, pain management, and patient safety. You are encouraged to ask questions throughout the session using the GoToWebinar chat tool. We will do our best to answer your questions throughout the session or at the end during the Q&A portion. Today's session will be recorded and posted on our website, www.virginiamasoninstitute.org. In addition, each of you will receive a link to the recording and question and answer document via email following this session. Thank you for attending. I will now hand it over to Ellen to begin the webinar, Beating the Clock to Stop Sepsis in 1 Hour.
Thank you, Holly. I'd like to welcome all of you and thank you for tuning in to today's webinar. Today I have the privilege of sharing with you Virginia Mason Health System's unique approach to stopping sepsis in its tracks and improve the mortality and patients that we serve. I'm sharing with you the work completed by our clinical and administrative stakeholder group, and I hope at the end of the hour you will have some new ways of thinking about not only early recognition and treatment of sepsis, but some broader thinking on how to engage your teams to solve problems. Sepsis is a complex and deadly syndrome that stems from the body's overwhelming response to infection. Let's first start our discussion on sepsis with our organization's alignment to our strategic plan. As you can see in our pyramid, we believe that all of our collective behaviors and actions in our organization must be measured against our patient-first belief. In 2014, an explicit executive physician and nurse leadership dyad was identified to lead sepsis improvement work. This work focused on early recognition and treatment of sepsis. Sepsis goal work remained a top strategic priority from 2014 through 2017, when results showed process stability and improved outcomes. This was an essential aspect of establishing the necessary alignment and cultural elements for achieving our results. As you can see at the top of our pyramid, our vision, why we exist, is to be the quality leader and transform healthcare. Today you'll learn how we've adapted Virginia Mason's Sepsis Power Hour into services that we provide to help you accelerate sepsis prevention and transform outcomes. For many of you listening today, you are well aware of these staggering statistics. There are more than 18 million cases of sepsis worldwide, with 258,000 Americans annually dying of the disease. Sepsis is the primary cause of death from infection, with a 28 to 50% mortality. And the third bullet, which helped guide our work, was that patients with initially less severe sepsis make up the majority of our sepsis deaths. In one study, septic shock was not present in 68% of our patients who died from sepsis. Consequently, improving standardized care for patients with less severe sepsis could drive dramatic future reductions in hospital mortality. Urgency to improve sepsis treatment was present at our institution as well. During 2008 to 2014, we had 2,276 deaths, and sepsis during that time was responsible for 47% of our total mortality cases. Interestingly enough, early in our journey to improve our sepsis treatment, our focus was placed on treating patients with severe sepsis and septic shock in our critical care. We realized, however, that although this was extremely important work, if we could prevent patients from a critical care stay, we could decrease the impact of sepsis on our patients and our communities. This required us to adjust our thinking and move upstream to consider scientific process improvements and a strategy for early sepsis recognition and early sepsis treatment. Our survivor experience also helped us frame our focus. Sepsis survivors experience longer length of stay with a high utilization of precious healthcare resources. They experience higher rates of readmission, and many of them experience long-term injuries that affect how their life can be lived after their disease process is complete. So leveraging our lean process improvement method, which we call the Virginia Mason Production System, allowed us to accelerate and succeed in our sepsis improvements. Our goal was to reduce sepsis related to morbidity and mortality in our patients by consistently delivering timely evidence-based care. Our work was based on the internationally recognized 3-hour Surviving Sepsis campaign. And studies have shown that speed is life when it comes to sepsis treatment. Recognition consisted of screening for systemic inflammatory response syndrome, or SIRS, and an identification of the source of infection. Our electronic medical record allowed us to screen for sepsis and see infection sources clearly. The next step was to initiate initial treatment without delay. What makes this recognition and treatment bundle unique and effective is that the registered nurse at the bedside was the one screening for sepsis and initiating 3 out of the 4 elements of the sepsis intervention bundle: IV fluids, lactate test, and blood cultures. No waits, no delays, early recognition, and initial treatment. Virginia Mason opted for a more aggressive target than the 3-hour sepsis campaign recommendations, because literature actually suggests that for every 1 hour of antibiotic delay, mortality increased over 7%. Additionally, early sepsis was targeted because 2/3 of those who died did not have sepsis on arrival to our institution. So our target boundaries for improvement were again from recognition of sepsis to antibiotic delivered. The purpose of this slide is to orient you to the high-level overview of the Sepsis Power Hour. The nurse-initiated protocol seen here on the left, which the team called SNIP, Sepsis Nurse Initiated Protocol, was delivered in 30 minutes or less and was instrumental in decreasing time to treatment and allowed us to demonstrate that time of sepsis recognition to antibiotic delivery could occur within 1 hour. You also see that the physician work included steps such as confirm sepsis, start antibiotics, and complete bolus. And the pharmacy work was to prioritize antibiotics, dose and prepare, and deliver to the patient. Activation of the sepsis nurse-initiated protocol allowed for parallel, synchronized, and standardized work to be executed by the nurse, the provider, and the pharmacist. And this point is very important. It was no longer a linear process. Study of the results showed that the nurse-initiated protocol was again a significant contributor to rapid treatment. So the solutions we've developed to help organizations improve sepsis not only include how to operationalize what we've discussed so far, it also includes coaching and facilitation to help you build integrated team and integrated processes. And this again allows for accelerated sepsis improvements so that a 1-hour response could be achieved at your organization. Team engagement to act quickly is key. The two elements of success for our Sepsis Power Hour included empowering the care team to take action and rapidly bringing services to the patient. Our sepsis treatment bundle shortens the reaction time at each step of the process, from early detection of sepsis to empowering nurses to swiftly initiate treatment, to the consistent and rapid delivery of continuous care. Communication and accountability across the sepsis team is a driving force for improving quality and timely care delivery. Our sepsis stakeholder team members included registered nurses, nursing assistants, phlebotomists, providers, pharmacists, and the project manager. Each role, with its accompanying dynamic standard work developed by the individuals and groups that do the work, allows for transparent accountability of each stakeholder. The importance of role clarity cannot be underestimated, as an established sequence of work based on standards helps the team respond and deliver timely care with each step and reduces process variations as they occur. I'd like to highlight one of the many important functions the project manager plays in sepsis improvements. Along with other responsibilities, the project manager role is designed to provide closed-loop communication directly to providers to recognize them when their quality standard is met. An example is the message that was sent to Dr. Calderon, one of our hospitalists. Thank you for using the order set and ordering antibiotics stat. The patient received antibiotics in 31 minutes, well under our 60-minute target. Project manager feedback is crucial, as feedback to providers and staff reinforces the behaviors and activities needed to improve and sustain this work over time. This is a quote from Virginia Mason's sepsis team project manager, and I share it with you because I think her thoughts reflect those of the entire team. So Alice says, I think the best thing about the Sepsis Power Hour is that it brings care to the patient without waits or delays. And it really leverages the whole multidisciplinary team, exactly where their skills and strengths are, and the ultimate beneficiary is the patient. This model allows for clear responsibilities and clear task alignment to ensure that a rapid response is initiated and held. Why don't we listen now to some more thoughts that our sepsis prevention team will share with you.
The Sepsis Power Hour is something where it's a nurse-initiated protocol where we can get interventions in place that we try to get done within an hour. So it's rapid infusion of fluids, broad-spectrum antibiotics, blood cultures are drawn, and a lactate are drawn.
In Power Hour, the patient no longer has to wait. As soon as the nurse suspects something, as soon as the patient starts feeling sicker or is having those changes in vital signs, we can really start the process right there and make sure that the patient gets the care escalated that they need right when they need it instead of waiting.
I can initiate interventions quickly that can help get things going for the patient. So we can start fluids or get labs going prior to the doctor showing up because we have the power to do that within our scope.
We are doing a really innovative practice model here with the Sepsis Power Hour, allowing the nurses to initiate the process. They're the right people to do it. They're at the bedside, they're with the patient, they can see what's going on. So giving them the ability to trigger the process was really key. And then I think also pulling in pharmacy into the solution rather than assuming that we were part of the problem.
I think it's really helped streamline and make my work more efficient and safe and more effective. It's provided the tools and the communication process to be able to get all the right antibiotics and the right labs within 1 hour that's necessary, that's going to make the most impact with the patient's life.
I've been involved in a few situations with patients that have sepsis, and it's been a great experience. I think it's a quick and effective way to get a lot of help that's necessary within, a short amount of time. I think it really works wonders, I think, with patients.
This has impacted patients in the way that the nurses can start implementing interventions as quick as possible, because sepsis is such a big deal and it is something we're really worried about. I mean, it can literally save lives.
I've seen nurses kind of more directed. They can give more effective treatments, I think, in the span of time that it takes to call and notify and page doctors. Now I've also seen patients react better. They're more at ease when they see nurses and doctors kind of more directed in what they're doing. They feel more confident and their family members are more put at ease.
And it's a great conversation to have with the patient's family as well, to say, we're gonna do this right now. It might be a little disruptive, but this is the way that we want to take good care of you as soon as possible.
All this work has been successful in that we are seeing time to giving antibiotics within the first hour being accomplished at a high rate, and to be saving patients' lives and having that kind of result shows that this is something that's very successful and should be continued.
What has really changed for patient and families? I mean, it's in the numbers. Our mortality rate has been decreasing year after year for 4 years straight, and it had plateaued for a good 4 or 5 years prior to that. So that is substantial improvement. Our rapid response call rate has reduced from 120 a month to 40 a month. So it's in the numbers. Care is better.
I think the best thing about Sepsis Power Hour is that it brings the care to the patient without the patient having to wait. So it really leverages the whole multidisciplinary team exactly where their skills and strengths are, and the ultimate beneficiary is the patient. So they get the care when they need it without having to wait, and it's amazing from the perspective of all the staff and the patient.
So let's review our results. Since the project began, Virginia Mason has achieved a median time from sepsis identification to antibiotic administration, the most critical element, to 47 minutes in the ED and 64 minutes in the hospital. That's down from 140 minutes for a decrease of 54%. And in 2017, we did begin to expand sepsis care work to our ambulatory clinics as well. Additionally, as Evan mentioned, successful results from the program also included a decrease in our hospital rapid response calls from 120 a month to under 40, with no increase in critical codes. So this was a decline in sepsis mortality from roughly 13 to 9%. Significant results. So if you're interested in accelerating your sepsis improvements, please contact us. We've adapted the program you've been learning about to help others achieve the rapid recognition and swift treatment of sepsis in under an hour. Through coaching and consultation, our experts can help your organization develop the structures, processes, and outcomes that will allow you to accelerate your sepsis improvements. Our hands-on partnership can empower you to develop your organization, learning from the experience to ensure that you create sepsis success. What is ultimately good for our patients is also ultimately good for the viability and cost containment of our health systems overall. 1 hour time to treatment with improved mortality is possible.
All right, I would now like to begin the Q&A portion of our webinar with Ellen Noel by posing a few questions that we've received earlier from attendees. Ellen, the first question is, what is the best way of ensuring that antibiotics are administered within an hour?
Thank you, Holly. It's wonderful to be with you all today. Antibiotics within 1 hour rely on 3 important steps. The first is early RN recognition of sepsis and rapid initiation of the nurse-initiated protocol, which we call our Sepsis Power Hour. The second is just-in-time physician notification that Sepsis Power Hour treatment has begun, so confirmation of treatment and antibiotics are ordered as soon as sepsis is confirmed. And finally, concurrent pharmacy notification of antibiotic need delivered without delay. Designing a process that allows for synchronized and parallel work to be done in a standardized way decreases the time to treatment and ultimately saves lives.
Thanks, Ellen. A second question from the audience is, what steps did you take to engage physicians in supporting a nurse-driven power hour? Was physician autonomy a challenge?
Oh, that's a great question. Physician engagement and leadership is essential to a successful sepsis campaign. Our accelerated success relied on identifying sepsis prevention as an organizational quality goal, ensuring that we had some executive sponsorship, and being very explicit on which physicians and nurses were on point to lead process change. Physicians are generally interested in collaborating to improve care. Physicians and nurse leaders leading this work were ones that were very respected by their colleagues and did spend many hours connecting with their peers, sharing progress and feedback, and using our improvement method. Sepsis prevention sustainability depends really on a system approach, and for us, a clear method to improve was critical to effect our change.
Ellen, what is the most effective screening tool utilized in ICU versus non-ICU areas?
We use the same tool in both areas. We use the Surviving Sepsis Campaign Guidelines, which is really the gold standard for evidence-based sepsis prevention.
And what is the single most enabling action a team can perform to improve their performance?
As the only healthcare system with over 16 years of experience in applying lean to improve the reliability of our healthcare processes and our outcomes, we have found that a single improvement method that activates teams to engage and learn through change is really imperative. Along with strong leadership behaviors, the practices of lean science, when executed correctly, encourage team activation and problem solving. And this also helped us sustain our sepsis order set use and protocol adoption. Lean methodology has allowed us to accelerate our work in sepsis and in many other areas as well, empowering our clinicians and those doing the work to design processes that optimize time to treatment and rid the system of dangerous delays.
Thanks, Ellen. Our next question is, can you provide us with your current forms, flowcharts, and checklists so we can implement this process at our hospital?
Thank you, Holly. That's an interesting question. The Sepsis Power Hour method includes the same essential tools and strategies implemented at Virginia Mason. By partnering with us to effectively address sepsis in your hospital, your healthcare team can benefit from our extensive experience in creating standardized processes, using our tools, optimizing flow, and preventing mistakes. Our sensei provide the intensive coaching and training needed to ensure your team is empowered to rapidly address the early detection of sepsis the same way, every time, for every patient.
Do you have a sepsis response team that responds upon positive ID notification, similar to a rapid response team?
That's also a good question. Yes, our code team response is part of our rapid response structure. So a patient who screens positive will receive a coordinated care team response that initiates next steps for treatment without delay. Interestingly, with implementation of the Sepsis Power Hour, our rapid response data has shown over time that the volume of overall rapid response calls have decreased from 125 to 35 per month. Imagine being able to use the healthcare team in a preventative way when the patient has the best chance of survival. This improvement shows that early detection, coupled with timely, synchronized response, can improve the way we use our people to deliver care. and that ultimately directly translates positively to our patients.
What EHR do you use, and how have you used it to help with rapid treatment initiation and care continuity?
The electronic health record. A rapid system response process is ultimately reliant on technology to get to zero defect delivery. Improving information flow with technological advances has truly helped us get to our finish line. Virginia Mason is unique, however, in that our staff studied the medical flows of sepsis patients using our lean methods before technology application. This ensures that information and process waste is eliminated, flow is optimized, and standard work that supports the human and technology interface is present, so reliability can be achieved.
Thanks, Ellen. This will be our last question for today. How would you recommend implementing a nurse-empowered approach in a state that has a stricter Nurse Practice Act around protocols?
Great question. Our Sepsis Power Hour relied on nurse-initiated protocol, as I mentioned previously. So first, you must understand your state's registered nursing scope of practice regulations. If nurse-initiated order sets are allowed in your state, follow national guidelines for creating, approving, and maintaining safe practices. There is a prescriptive approach to organizational policy for nurse-initiated orders. Physician oversight and nurse training and competency are just a few of the key elements. The Joint Commission and Agency for Healthcare Research and Quality are good resources to start with.
That is all the time we have for questions on today's webinar. Thank you, Ellen, and thank you to all of our attendees for your participation today. As stated earlier, this webinar is being recorded and will be posted on our website, www.virginiamasoninstitute.org, under the Knowledge Base section. Additionally, all webinar attendees will receive the recording and a question and answer document via email following this session. We encourage you to explore our extensive knowledge base on our website, which includes case studies, articles, and helpful lean tools. We also invite you to connect with us on Facebook, LinkedIn, and Twitter to stay up to date on lean healthcare topics. If you are interested in continuing your learning, we have a variety of ways to support your education. You can learn about our training and services, including workshops, coaching and facilitation, and organizational transformation services on our website. Again, that's www.virginiamasoninstitute.org. And you may also email us directly at info@virginiamasoninstitute.org. Thank you again to Ellen, as well as everyone participating in today's webinar.